And I've gotten the cue that we are ready to begin. So thank you all very much. This is a joint committee session between the Health and Human Services and Public Safety's committees. We are going to get an update on our mobile crisis teams and the efforts made by DHHS, law enforcement, and many others to stand up those teams, and also get an update on the model that we were presented regarding Crisis Now, which unfortunately we have since learned did not receive the grant application that we had applied for. But nevertheless, a lot of the work that was done to stand up that proposal has been extraordinarily helpful, and we will get an update on the efforts of that coalition of organizations to move that forward. And I also want to acknowledge that this council has been very supportive and aggressive in looking at different models, and very much appreciate the leadership of Dr. Crowell and his team, as well as Police Chief Jones and his team, and looking at creative solutions to shift the manner in which the county responds to mental health challenges in our community. This is particularly important now, and I'm proud of the efforts to date, but know that there is a lot more work that needs to be done. So, Mr. Chairman, I turn it over to you to make some opening comments. And then after that, I will turn it over to Dr. Crowell and Chief Jones to make some opening comments. And then we will begin walking through the packet. So,
well, thank you very much, Mr. Chair, and thank you to everyone for being here. And thank you to Linda McMillan for another comprehensive, informative packet. It truly is. In July, the County Council unanimously approved the funding for the additional 6 licensed mental health clinicians to the Department of Health and Human Services. And of course, years prior, we all launched, I certainly worked on it, and others on this call as well, launched on having mental health courts in our district and circuit courts. And I believe that was a necessary step to decriminalize mental illness and move towards racial equity and social justice for all residents. We are closer to ensuring that all residents who experience mental health crisis receive appropriate therapeutic responses. The additional clinical positions will go a long way in increasing the capacity of our already exceptional mobile crisis unit. And we all look forward to receiving an update today on the mobile crisis teams and taking that deeper dive into the development of a strategic, holistic crisis response system. There are 3 components that I think we should highlight and prioritize. And the first is the development of the operational procedures that ensure the safety of residents experiencing mental health crisis and the clinicians who serve them. Second is providing an ample opportunity for input from residents and mental health professionals lived with their experience. And the third is dedicating appropriate resources to crisis response and related health and social services so that the public safety and criminal justice system are not forced to fill those gaps. I'd like to thank everyone for being with us today. And Mr. Chair, I'll turn it back over to you. Thank you.
Thank you, Chairman Katz. And we've been joined by my colleague, Councilmember Hucker, who I was proud to work with on leading the initiative to expand the mobile crisis unit, and appreciated working with his office in that regard. What I'd like to do now is have some opening comments from Dr. Crowell and then Chief Jones, and then turn it over to Linda McMillan to make some opening comments regarding the packet. Dr. Crowell.
Good afternoon, everyone. I'm happy to be here with you to talk about this piece that has, as you all know, has been a long-standing challenge and for the county, and something that I come to with a lot of passion and a lot of concern. We want to give you an update on the work that's in progress, both within HHS and across and with other departments and partners. The Crisis Now model, as you've outlined, is outlined in the package, and as you all have heard from other conversations, is I think of as a larger comprehensive frame that addresses several of the issues that go into making up a full and a comprehensive crisis response process. A collaborative crisis system, a mobile crisis team that is 24/7 with the addition of peer support. Decoupling crisis response from law enforcement response is a significant issue. The model also involves establishing a restoration and stabilization center and creating a central call center process. As we went through this process, as we've gone through this process today, we've talked to we've looked at a lot of programs from around the country to try to learn from them about what they do and how they approach these problems. We looked at the Asante group that's operating here in the county, in Maryland, and in other parts of the east along the Eastern Seaboard. We also drew on the experience of our own mobile crisis team members in 30 plus years, some of whom have been at this work for a very long time and have been continuously training around and considering alternative strategies, and our local partners. But we also looked at another model called Cahoots that has been much touted and much reviewed. And I think that as we move forward, we will be looking to engage some of those groups to help us build a better response system through a variety of different ways. There are some common elements around this process that we have to understand before we get into this today. One of them, and part of this review, I think, today is about that. One is understanding what we have in place and the existing points of collaboration and partnership in responding to the needs of folks who have mental illness, who are homeless, or who are at risk of law enforcement or justice involvement. We have, in this conversation in the last 7 months or so, wrapped all of this up under the heading of mobile crisis response or mental health crisis response in our public discussion. That conversation included mental health, substance abuse, homelessness, community engagement, and outreach to homeless populations. There's a reality that a lot of that exists in the county, but it isn't necessarily connected, certainly not connected always in the public mind, and sometimes not in our minds, and sometimes and often not in a more coordinated or integrated fashion. So to look at some of this, we have mobile crisis and outreach teams that exist through our crisis center, but insufficiently sized and staffed to meet the needs of the county. We have partners who provide outreach and engagement for homeless people who are on the streets that needs a new look, a fresh look. We have STEER that does outreach for substance abuse, peer support for substance abuse, and facilitates recovery. We have a street outreach network that engages the community on the streets. They've got to get melded into what I'm considering a mobile crisis and outreach team. We've never had and have long desired restoration and stabilization. And we've talked about this for many years. And back when we were last looking at it, there was a point in time where we had to make a choice between working and focusing on a mental health court and restoration. And at that moment, we chose to go in the direction of mental health court because it seemed to be that moment in time to do that. So restoration and stabilization got put on the back burner for a moment. I think it's time for us we have to now come back to work on that. The third piece of this, the model is a central call service, and it's described that way in the proposal. It really should have been described as a coordinated call service. Right now we have 911, 311, a couple of hotlines, both county hotlines and national suicide hotlines. We have the crisis line and shelter services numbers that people all call depending on what they see as a surface level need. If you don't know where to call, you call 911. If you're a little more sophisticated, you call 311. If you really know something about the system, you might call the hotline or the crisis center or get referred to those. All of those models have to now meld together to be able to respond and to triage and get the right people out at the right time. The Cahoots model, when we looked at it, for example, responds only to 17% of the calls that come into the police department in Oregon. 17%. They are dispatched by a police-staffed non-emergency call line. So we've got law enforcement sort of looking at it and triaging and making a decision. Do I send an officer in a patrol car? Do I send someone else? Or do I send the Cahoots team out? So that decision gets made at that level. We have to be able to do that here and then triage in real time what the appropriate level of response may be. Whatever we call this model, whether it's Cahoots or Crisis Now or something else, it has to have a priority engagement for policing for engagement without policing and a triage process for that response. so that we can decide quickly whether it's a mobile crisis team, whether it's an outreach team, whether it's peer outreach, emergency medical services, or in fact the police, and need to be involved in the response. And then training on how we triage cases as they come in. I think we have to have some coordination across all those levels of response that I talked about earlier, both for some initial response, who's there first on the scene, and how do they make sure it gets handed off to the appropriate person. We have to engage with partners, hospitals, community providers to deal with arrest and emergency department diversion and alternatives to service. And that is probably one of the places where we are going to have our biggest sticking point is what are our alternatives and what can we legally do with people. So there's some advocacy I think that needs to happen around how we deal with what laws we use as the basis for our response process. And I think the last piece of this has to be, we have to train across all these parts of the system on de-escalation, on assessment, and on engagement of people in ways that are that respect and reflect the humanity of all the parties that are engaged in a process, so that we're not escalating and creating negative responses. We've got the pieces around this. You know, when we initially submitted the plan, our plan was to form a collaborative and to ensure that there was input into the plan from our partners and providers and from community members. And while we were waiting on the grant to bring people together, we have worked on pieces of this that you're going to hear about. But not getting the grant doesn't mean that we don't need to proceed with creating and convening that collaborative. So we at HHS, we will commit to taking on the responsibility for convening that collaborative, for bringing folks together, taking the next steps of recruiting our staff for the rapid expansion of mobile crisis, but also bringing those other pieces together in a way that melds us into a collaborative system and figures out what our next steps are as a collaborative. So I'm mindful that we also have a parallel process in reimagining public safety that is in operation now. As they complete their work and make recommendations, we will look at those recommendations through this collaborative and then respond appropriately to the things that they have recommended that be included. So I think that will be, that's the framework that I've seen in this process. And I know I've answered some of the questions that maybe Linda has posed in this, but I'll let you know that we are not sitting on our hands because we didn't get the Crisis Now funding. We're going to keep going on this. So thank you.
Thank you, Dr. Corral. That was a great overview. We'll get into more specifics as we go through the packet, but and after Police Chief Jones, my colleague, Councilmember Rice, will make some opening comments as well. I'll then introduce the members who are here to respond to questions, and then we'll go through the packet. So, but Police Chief Jones, if you could make some opening comments.
So good afternoon, council members, and thank you all for allowing us to speak on this very important subject. I must tell you all when I found out that we were not getting the not selected as for the Crisis Now grant, I was very disappointed, and I'm very disappointed for the fact that when I first saw this the outlay of this program, I really thought it was the perfect fit for Montgomery County. And was something that I was very excited about from the moment that I heard about it. And so with that being said, that's a little bit of my frustration because as I've noted to these committees before, that I believe that there are these, particularly a lot of moments that we in law enforcement should not be involved in answering some of these calls for service. Dealing with some of the clients that are in the mental health, having mental health issues as well as addiction issues, and that there is a way to, we think that would be better served, even if we did get the call, that we would have the ability to actually take these folks to a facility where they could get the actual services that they need in a very timely manner, and you would be able to free up law enforcement, our police officers, to be back on in their patrol beats in a very more timely manner. So with that being said, I just, again, I support if we can figure out a way to move towards a model program like this. I am, Dr. Crowell and I have talked this through several times about the different ways that we think this could be actually functioning, given, if we had gone through the grant process. But I think that there is some major benefits. One of the things I think that, we really have to talk about is when calls 911 becomes the panacea for the larger community, and they're going to pick up the phone. We have to understand this, and the 911 center is where these calls primarily will probably be coming to, for the most part. And we would have to have a change in a paradigm in our community to get them to understand that there's another way to pick up the phone and call another resource for individuals going through these types of crises. But in the meantime, we would still have the ability to transfer those calls if we had a particular call center that would be able to accept this. And I think based on what Dr. Crowell has noted, that would be something that could be created, and we should really be working towards that. And while I'm speaking to that, as Dr. Crowell has also noted, as we all know, in the middle of the we're in the middle of the reimagining public safety process. Their recommendations are also coming, and an audit is coming its way. And I know that they're also looking at some of the functionality of the police department as it relates to that. And we're well prepared to be able to provide those things that the answers to the questions that will come about how we handle different types of calls for service. The one thing I want to make sure people understand, and I'll stop here for the time being, but that a lot of times calls come in, they're not exactly always what we think they are when they come into the 911 center. And everybody has to make sure that they understand that. Is that sometimes it does require us to go and sort of evaluate what is exactly happening, and then be able to make a recommendation of services maybe to someone else that is not a police call at that particular time. So I want to make sure we're not getting lost to think that police are totally going to be out of the picture on this. There are times when we're going to have to escort HHS employees, social workers going to some of these calls because there's a potential that there may be some issues. We want to make sure all of our county employees are safe when they are out going to do the responsibilities that they do. So I just wanted to make those points clear as we continue this discussion. But thank you for allowing me to say a few words right from the beginning.
Oh, thank you, Chief Jones. And in addition to Dr. Crowell and Chief Jones, we are joined today by Carolyn Sturgis, Scott Goldstein, our Chief of Montgomery County Fire and Rescue Services, and of course, Caroline is the Assistant Chief Administrative Officer. We're also joined by Dorn Hill, the Acting Administrator for DHHS Trauma and Crisis Services, Athena Morrow, the Manager of DHHS Adult Forensic Services, Amanda Harris, Chief of DHHS Services to End and Prevent Homelessness, Leslie Graham, making a second appearance before our committee today, the Chief Executive Officer of the Primary Care Coalition, and Ms. Susan Donovan, the Managing Director for Nexus Montgomery. And before turning it over to you, Councilmember Rice, to make some opening comments, I'd be remiss if I didn't invite Chief Goldstein to make some opening comments as well. So Chief Goldstein, if you could make a few comments just to lay the groundwork, and then I'll turn it over to Councilmember Rice, and then we will dive into the packet. Chief Goldstein.
Councilmember Robert Haas, thank you very much. And the other members of the fire rescue team are present, as well as with the leadership of Avital Graves, who is our mobile integrated health program manager, Alan Bush, Ben Kaufman, and John Kensley from operations and EMS are present to help through the discussion. As Marcus outlined, and the mobile integrated health process has been in place for about 2 to 2.5 budget years now. We have a great partnership with HHS in our innovative approaches to addressing the community's health needs that alleviate or remove 911 as their safety net, and provides them other resources, other opportunities before they need to revert into the 911 process. So absolutely, the Crisis Now model and the opportunities to partner together what we're all here for. And I thank Avatar and her team and everybody in fire rescue for the partnership to this application. And we will adjust and move forward by far. So thank you for the opportunity, but the team is here ready, and we'll be creative and figure out steps to succeed forward.
Thank you, Chief Goldstein. Turn over to Councilmember Rice to make some opening comments as well.
And I'm going to just be very brief. I just want to highlight a perfect example of why this is needed so much. A gentleman who continues to persist in placing himself at the intersection of 118 and Middlebrook Road, who stands in the way of cars and continues to have the police called by our community, because they're going to call 911, as you heard the chief say, because not only is this person presenting a safety risk to themselves, but also to those individuals. And no one has any idea of what the person may have, whatever the case may be. And so when they call, what are our police officers supposed to do, right? For a person who refuses mental health medical treatment, who does not want to go to a hospital to receive care, but who is technically violating the law by being in the way, impeding traffic. But are we now going to tie that officer up with trying to process and arrest this person, knowing that tomorrow they'll be right back out on the street again and doing the exact same thing? This is why this model is important. And the reason why is because so that it doesn't escalate to the next level. What I just described is the basic incident, but the time in which that person then pushes an officer or assaults the officer, and then the officer has to go hands-on with the individual. And we've seen where cases like that across the country have gone possibly in a negative direction. We want to avoid that, if at all possible. And that's what this model represents, a way for us to take, and this is real world, folks. This is happening in Germantown pretty much every couple of days, every 3 to 5 days. This gentleman keeps presenting himself. These are the kinds of things that, again, with a program that's out there that gives assistance to making sure that we can have a team intervene, a person who's sitting at a bus stop and sleeping there. I shouldn't have to call my police to be able to have them and assist them and say, hey, do you want services? We can get you help, and really talk to them about, convincing them that that's the way to go. I shouldn't have that burden on our police officers. Our police officers are there to enforce our laws and protect and serve. And certainly by that, they certainly get training, mental health triage training, and a little bit more than that. However, it's not at the same level as some of our behavioral health specialists. And that's really what we need in a lot of these instances. And I equate it, just last thing, Mr. Chair, similar to what happens in hostage negotiations. In hostage negotiations, and the chief can tell you, there are certain people who come in who are specially trained to specifically deal with those types of instances. It's the same sort of scenario. Having specially trained folks who are there, who are called out to say, this is a special instance. We need you in this case. It's not to take anything away from our police officers and the ability and things that they can do, but we need folks who really can and are specially trained to intervene and deal with these types of situations. So I'm very excited about this. I think that it has real world potential in terms of saving people's lives and really is going to make a difference in our community right away once it hits the ground.
Thank you, Councilmember Rice. And I want to apologize. I mispronounced Ms. Hill's first name. It's, of course, Jernay, and I'm drinking a coconut-flavored seltzer water in honor of your backdrop. Need a little umbrella in it. But thank you so much for joining us, Ms. Hill. Councilmember Hucker would also like to make some opening comments.
Thank you, Mr. Chair, and sorry to be wrestling with my laptop to get on in time. Thank you all for being here. I'm really encouraged by everyone coming together today to lend expertise and skills to this really important problem, as Councilmember Rice outlined. I hope we can leave today with a real clear path forward and a solid timeline for the next steps, both in terms of any additional funding sources, but in particular, our multi-agency task force and what tasks they are charged with getting done by what times, date certain. I was, like all of you, disappointed to learn that we didn't receive the Crisis Now grant. I really appreciate the help from Ms. Graham and Ms. Donovan spearheading the application. I know firsthand how hard it is to write grant applications, and it's especially disappointing when you don't get the outcome you want. And I'm glad it won't delay our progress on this, while it will delay the a couple of the pillars, particularly the Restoration Center and the dedicated call center. I'm certainly grateful to everybody on the Reimagining Public Safety Task Force for their work helping us to figure out the next steps as well. I'm foremost in my mind, though, I'm wondering, since we passed the supplemental appropriation in July for the expansion of the mobile crisis teams, I've heard from community advocates. I've certainly wondered myself why this seems to be so slow at advertising and hiring the positions. There were folks when this first came up back in July who said this is sort of putting the cart before the horse. We shouldn't appropriate any money before we know exactly what we're doing. And those of us, especially Mr. Albornoz, who are very familiar with county hiring processes and the slow pace of them, said, no, we actually should push forward and try to fence off the money on the front end and let the hiring process begin, so that we're not in this position months from now without having any personnel. And we can do two things at the same time. We can move forward with the task force and figure out exactly what's the right approach for Montgomery County while the hiring process is continuing. So I don't know if we want to talk about it now, Mr. Crowell or Dr. Crowell, or later if you're going to get to it. But I just want to make sure that we have a path forward and are advertising the position quickly.
So those are excellent points, Councilmember Hucker. It is on the agenda for us to discuss specifically. We will get to it. And Ms. McMillan did an amazing job laying this out so that we can get to all of these respective questions. So prepare an answer, Dr. Crowell, but I think you already knew that was coming. A very good question. And I agree with you, Councilmember Hucker, that having a clear direction after this is what we're striving for. So Ms. McMillan, I want to thank you for putting together, as Chairman Katz said, yet another fantastic packet. There are a number of items. And I think the agenda lays out very nicely as an extension of the specific overview that was given by all of our colleagues on the panel. So why don't we start with, as proposed in the agenda, an update on the Crisis Now grant application. As we all know, we unfortunately did not receive the grants, but that the infrastructure that was set up and the discussion and coalition building that was established is very important. And so we'd love to hear maybe from you, Ms. Graham, to start on if there are any updates. I know that there was an opportunity to potentially appeal and where we are with that. And then anything you can add, or Dr. Crowell or anyone else, on what the plan is in the short term to implement some of the elements of the plan, acknowledging that there will be resources needed to fully implement the plan. And then if we can have a brief discussion on what we're talking about in terms of those resources, what the cost might be, and then so that my colleagues and I can deliberate and discuss, not necessarily today, but in the very near future, how we can fund the entire initiative. So Ms. Graham, if you could provide an overview, that would be great.
Sure, thank you very much. I'm Leslie Graham, President and CEO of Primary Care Coalition. In addition to Susan Donovan, I have with me today Elizabeth Arendt, our Director of Provider Services, who led the collaborative proposal design as well. Just to set the stage, Primary Care Coalition, or PCC, we are the managing entity for Nexus Montgomery, which is the coalition of all 6 hospitals in the county, when they work together on shared programs that can jointly benefit the community overall. And PCC facilitated the collaborative design earlier this year, as we know, among Montgomery County Police Department, Fire and Rescue, DHHS, the hospitals, EveryMind, others in the community, to build out this proposal and to look at behavioral health systems, crisis systems change, and setting priorities within the evidence-based framework of Crisis Now. Unfortunately, and I think a shock to all of us, given it was, in the words of Chief Jones, a perfect fit for Montgomery County, the proposal was not funded. We did debrief with the Health Services Cost Review Commission at the state. They commended Montgomery County on the extensive collaboration that was proposed, both in doing the proposal design and in the ongoing operational involvement of how the plan for moving forward, and also commended us on the impact outside of traditional healthcare and hospital systems in terms of really making changes within county agencies, police, fire and rescue, DHHS, the crisis hotlines, which also include EveryMind. So they were very complimentary in that regard, but they did state that they received 9 behavioral health crisis system applications from regional partnerships around the state. And due to resource constraints, they are recommending funding only 3. They also stated there would be no further Crisis Now funding opportunities coming out of HSCRC. So unfortunately, HSCRC is not going to be a path forward for funding this particular work. The Montgomery County hospitals recognize that the behavioral health crisis system and making changes to it is a priority and a challenge for the hospitals to address as well. Behavioral health crises affect the emergency departments, the hospital utilization, and the ability to meet state total cost of care goals in the Maryland waiver with CMS. So very important to the hospitals as well that work on Crisis Now, on behavioral health crisis systems change continues on. Like the county, hospitals also are in budgetary constraints due to pandemics, but we need to look for additional funding and explore ways to continue to collaborate together. For example, given that the Community Crisis System Collaborative or some sort of a advisory or governance body is sort of a foundational piece to this work, PCC did submit a small grant application to Robert Wood Johnson Foundation earlier this week that would allow the creation of the patient and family engagement side of that with an equity lens. That was a piece of the proposal, was to be able to have the Community Crisis System Collaborative have patient, family, and caregivers with lived experience have input to that. So we'll see where that goes as well. I just wanted to say, it's been a pleasure working with all of you in this design. It was really a wonderful collaborative. Like all of you, we were very shocked that the good design that was built was not funded, but want to say, please continue to keep us, PCC, the hospitals involved. We are a community all together. We all are working on, we all have reasons to want to make changes in behavioral health crisis system and want to continue working together on this.
Ms. Graham, can you remind me how much the grant application was for?
Sure. They did ask for a reduction in budget in August. The final budget that was submitted was about $17.5 million over 5 years. So that's a total over 5 years.
Okay. And that primarily would have funded additional positions or some of the system building? What were just the highlights of the specific line items?
Yeah, so there were 4 main areas that it would have funded. So one was the community crisis collaborative. So the sort of the oversight body. So running of that, as we know, any meeting requires staff. So running of that, as well as getting the patient and family engagement and the engagement of behavioral health providers. So that was one piece. The second piece was it funded peer navigators for the mobile crisis outreach team until such time for about 3 years, until such time those could be built into county base budget. It funded some goods, cars for the additional mobile crisis outreach team and for fire and rescue so that they could do unmarked transport. And it funded the startup of the Restoration Center. The Restoration Center, as planned by RI International, is largely self-supporting once it's up and running, but it has a fairly high startup cost as you do a build out of a technically difficult building that has to be secure. And also as fire and rescue and police alter their practices to create drop-offs at the Restoration Center, it takes a while for it to become up to full 100% utilization. So it was to cover some of the lack of funds that would come in through billing. But once at 100% utilization, it should largely be self-sustaining with the exception of those who are uninsured.
Thank you, Ms. Graham. We, of course, were all excited when we were briefed on this plan back in July. Dr. Crowell, is there any of this that you think the county is in a position to be able to absorb to move forward with an existing budgets, or have there been discussions or plans about the possibility of seeking an additional funding source? What are your thoughts, or what's the plan in lieu of us not receiving these funds?
So you'll hear a little bit from some of the team members about where we are with the work and how we're moving forward. I would say that a couple of things. One is where my note? I just want to get to the note that I was looking at. Yeah, there it is. That the peer navigators were when we got the 6 therapists. Our goal in working with Nexus, the Nexus group and around the Crisis Now funding, was to add a peer specialist to each one of those teams, so that we would have 6 standing crisis response teams, mobile crisis response teams. Absent that, we are now looking at using our crisis center staff and folding that in there, so we have some backup and support. But we're looking at, memory serves, 3 crisis response teams that would run down, and we'll regionalize them. So there's one down county, one up county, and one mid county, so they have capacity to respond and to back each other up as needed. So it'll increase capacity, but not quite at the level we would have gotten had we had the peer specialists in that team. The other piece of this, the other big piece of this, of course, is the restoration center or stabilization center. That piece, we have been looking at trying to work out a program of requirements for that, to try to understand exactly what that facility needs to look like and how big it needs to be and how well it needs to be structured. That was part of the work that we would have done under the collaborative, but would have also involved county government and sort of having those conversations. There is no reason for us not to move forward with at least thinking through and maybe costing that out for us, although that may take a little longer than we planned, because we're working on there's another major project we've got them working on. But we had always envisioned that not being online right away in this process. The challenge, of course, will be the ongoing operating costs. As Ms. Graham points out, the grant would support some of that for a time until we could make it self-sustaining. There's a lot of back and forth about and details to iron out about what would make it self-sustaining and how we do that, and whether or not it's self-sustained by Medicaid, Medicare funding, or private insurance funding. Details that need to get worked out again. And then the last piece, I think, is the effort of the collaborative process. And as I said, that piece we can continue. We have to bring folks together to do that collaboration. So hopefully PCC will get the grant that they've applied for, to bring the team together around, to bring patient and family to the table to work on the equity issues. But we will continue that process because it has to happen in order for us to build a collaborative system. So we'll be looking to bring police, fire and rescue, Every Mind, our call center folks, our hospitals to the table to talk through that process about what this should look like, and to help us to think through policy and procedure and next steps. So those pieces can go on. I think there's a question about tools and support. I believe we had factored in the tools and support necessary to stand up our crisis teams now, if I'm not mistaken. Dorney can correct me on that if I'm wrong. It was the expansion out to 6 full teams that may have that we would have looked for additional support from the crisis center. So we're not able to expand to 6 teams and have the support around that, and we're not able at this point to do the restoration center, but we can continue the work of developing a full model. And as for the call center, I forgot, part of that collaborative process is developing this, not a call center at this point, but a unified kind of call response process, so that folks, because we're going to have, in addition, I'd forgotten to mention, we're going to have 899 as a national suicide hotline number in the very near future. So there will always be another number to call. The challenge for us is to make sure that those folks are all doing the same thing when they come on board, when they get a call.
Did you want to ask anybody else from your team to elaborate on any of that, Dr. Crowell? Or
I don't know if you're going to go through sequence or not. I know that Dorney has been working on the mobile crisis and outreach pieces of this, and she will have some information to share with you about where we are on this. So if you want to do that now, we can do that. I think that's fine.
Sure. Ms. Hill?
Sure. Good afternoon, everybody. Can you hear me okay?
Yes.
Good. So we have done extensive work looking at mobile outreach response and protocols across not just our recent region around us, but also working with RI International. Elizabeth Aaron has helped us research some of their best practices. So in your packet, I think you have what we call the Mobile Crisis Outreach Dispatch Protocol, and that addresses how we intend to utilize and restrict the intervention needs for the police to accompany us on every call. So we looked at the one thing I do want to note is that 11 p.m. or midnight to 7 a.m. everyone in the region has police respond with mobile crisis because there are increased dangers at night, lighting, different situations, walking into neighborhoods that you're unaware of. So that is one time that we are saying that we were looking to have police accompany us at all times. Also, the change is that the crisis would be based upon the caller's definition of a crisis versus the call center defining for them that they're in a crisis. So if someone calls and says there's someone in the middle of the street dancing, shooting arrows, we're concerned, we're going to go and respond and figure out what the need is. What's the concern? We're not going to wait to see like, oh, did you call the police? Is it a substance abuse? So we're going to expand our call delivery for homeless, mental health, and substance abuse, or domestic violence and other crisis issues. So there will be a training component that the current therapist and the sixth therapist that will come on board will need to have to expand our knowledge base for assessments of different levels of crisis. Additionally, Mr. Hucker, the positions are ready for advertisement. I know that you had questions about that. I actually sent forward the information yesterday, so they will hopefully be advertised in the next week or two.
Thank you.
We had to update the position description and some other technical pieces to make sure that we were hiring staff that had the needs to meet the new mobile crisis outreach model. So that has been taken care of, and we are moving forward with that. Additionally, I have added in where we compared what we currently do in our current service delivery and how it compares the similarities and differences between Cahoots and the Baltimore County Mobile Crisis Team. That's also in your packet. The one difference is that we respond regardless if the client wants us to come or not. And that is one difference that the Mobile Crisis Team in Baltimore County and Cahoots says that if the client does not want the service, then they do not continue to engage. We continue to engage regardless of if the client feels they need an intervention. So we will talk to them, build rapport, and still do a full assessment in the moment to see what we can do and offer them options, regardless of their willingness to talk to us. Also, looking at the three teams, one team would be 24/7, based in Rockville, and they would be the middle of the county and the backup for the two regionalized teams. We use ECC communication data and data from the small frame of calls that we do get currently. And the ECC data does include 311 because when someone calls in a crisis, 311 sends them to the 911 dispatcher and stays on the line. So the numbers are comprehensive of 311 and 911. And those statistics are also in your packet. So looking at the highest call levels for abuse, abandonment, neglect, harassment, mental disorder, Up County and Silver Spring and Bethesda area seem to be the highest catchment areas. So our plan is to work with our counterparts to try and find space down county for Silver Spring and up county in the Germantown area. And our hope is that Monday through Friday, 7 a.m. to 11 p.m., we would have one team at each site. So that would give us 3 teams from 7 a.m. to 11 p.m. Monday through Friday. We would still have the one team overnight, and we would still have the weekend team coverage by our current crisis center and PRN staff that we are hiring to fill in.
Ms. Hill, real
Yes.
quick question. That is a really good overview. The 3 areas that we're looking to stand up, are you envisioning standing those up simultaneously, or will there be a staggered approach on, obviously hiring has its challenges. As was alluded to earlier, I'm very familiar with those challenges. But are you envisioning starting in the Germantown area, the Silver Spring area, or the Mid-County area, or standing up all 3 at the same time?
Our goal is to stand up all 3 at the same time. We are going to revamp our training protocol. We're hoping to bring everyone on at the same time, if all the stars align, to have all the staff trained at the same time, so they would be their own cohort. We would train them in the model, have the cars, have the locations, set them up, and then be up and running all together at the same time.
Fantastic. And if we had received the Crisis Now funding, we would have been able to expand, but we still are moving forward with these three particular locations with teams able to dispatch in those areas.
Correct.
Okay. Councilmember Hucker, it looks like you may have a question. Oh, yes.
Yeah.
Thank you.
Thank you. It is always tough on these screens to do that. And I appreciate I guess if we go through the packets, much of this information needs to be discussed again or certainly touched on again. But one of my concerns is, and I believe we need as many teams as we can possibly have, but what happens if someone is sick on one of those teams? How are we able to keep those teams going with the limited number of people we're going to have?
So right now we utilize PRN as needed therapists who are trained. And we are also advertising for those positions as well. And that's the pool that we pull from. And we just need to work on our recruitment. And we've met with HR about how to really pinpoint different communities and areas to try and find more therapists who have language capability and the skill set that we're looking for. So we will also have PRN therapists that can fill in when there's sick calls or holidays and different things like that.
And PRN, I'm not familiar with PRN.
Sure.
Is that the nurses? What is PRN?
So PRN, they're therapists. It basically means as needed. They are temporary staff that we use because we are essential service. So there's a pool of people that we interview and keep and train just like we do our regular staff. They just don't have a set schedule. They're not merit employees, and they do come and cover the service as needed.
And there's an unlimited supply?
There is not an unlimited supply. Right now we have approximately 15 to 20. We would need to increase that by at least 50%.
Councilmember, let me just, Jordan, just correct me if I'm not mistaken, but I think one of the things we talked about, we had debated at one point about standing up a completely separate program called Mobile Crisis and Outreach. But at the end of the day, because of just this issue about staffing capacity and availability, we made this a part of our full crisis team staff, which means that our crisis team staff are available to do mobile crisis on a rotating basis. So if one's out, we can ask another one to step into that response role. And what's different about this is because we've added additional staff, we can commit to prioritizing standing up the mobile crisis and mobilizing the mobile crisis teams as needed.
Correct. So we have 27 merit staff that we can pull from to fill in the gaps as needed.
And I guess one follow-up question. Councilmember Hucker and I recently participated in a meeting with the Silver Spring Chamber of Commerce. And I know there have been groups that have been meeting in Silver Spring and in Germantown and in other parts of the community, trying to come up with a holistic approach to deal with, in part, the homeless issue, which crosses over into mental health issues. Could you talk a little bit about, Ms. Hill, how these teams will be interacting with the community to proactively find those key stakeholders in those communities so that there can be sort of a community-wide approach, acknowledging that, you know, these teams are going to be overwhelmed at times, but if there's a proactive way on maybe even preventative services as we identify people that reside in these communities. Councilmember Rice's point about the gentleman in the northern part of the county is the perfect example. You know, how is that collaboration going to work, and how are these teams, in addition to responding to crises, going to work with the community?
Sure, I can answer that. So part of what we've been doing are talking to not just our HHS partners, but our other partners, and we just haven't made it to the community yet, which is why I'm excited to hear about this collaborative approach that we are going to take about looking at the work. That's also why we're looking at placing them in the community, close to bus stations, close to community centers, so that they can go and be a part of activities. They can be in the community. People will know who they are. And, you know, we're even working on a special phone number so that people will know exactly how to reach mobile crisis. So there's lots, it's also about marketing, and they will be in the community. They can walk around, they can meet people, not just in a crisis, but, you know, at activities and other events, so that they know that we're there to support them in the community.
That's terrific.
Okay.
Was there anything else, Ms. Hill, on this particular component and the mobile crisis model that we're going to enact that you'd like to also talk about or stress or highlight? I know one of the questions was regarding should the county be advocating for Medicaid funding for mobile crisis services. Dr. Crowell, you talked a little bit about that in your opening comments, but is there anything else that we should know now as we stand up these very important groups?
Not that I can think of that I haven't mentioned. Dr. Kroll spoke about the need for peers, and, you know, to help navigate with the team. If we were able to, you know, have 6 to 8 peers, we could put them with the 6 new therapists. We could have almost 2 or 3 teams, which would be like 6 teams all day long. So we're just looking on how we can partner with others' resources to hopefully set up that that work.
So, Councilmember, I would add that peer recovery specialist is a growing field of specialization across the country and across the state, and there is a state level training for peer recovery specialists that people would need to take. And one of the things we anticipate the state and hope the state will eventually do is create a funding stream that pays for the work of peer recovery specialists. And we would hope that would also include mobile crisis response, restoration center response, et cetera.
Terrific. Thank you very much. I skipped over an item because that was the perfect continuation from the beginning. I'd like to jump back up to the second item on the agenda, which is to discuss the sequential intercept overview. And I believe, Ms. Morrow, you're going to brief us on that.
Good afternoon, everybody. Thank you so much for including me in this presentation. Some of you have heard me talk about the sequential intercept map before, but for some of you it may be new. So if you have heard this before, please bear with me. This is a model, it's a system developed by SAMHSA of looking at a community and the flow of folks from beginning to end when somebody is in a crisis, especially when they come into contact with the criminal justice system. So it's a way of looking at a whole system and the opportunities for responding with behavioral health services at all these different, as they call them, intercepts. I would like to, I don't know if someone can share the schematic that SAMHSA developed so that we can actually look at it. I can do it, hang on. Linda, can you figure out a way to share it for me?
I don't have it as a single slide. It is on page 2 of the packet. If people have the packet, circle 2.
Okay.
I don't know if you can
Okay.
share.
But I can actually.
Screen sharing has been enabled.
Okay.
So the idea behind it is that where the intersection between behavioral health and criminal justice happens, there are opportunities to intervene with supports and resources, and either serve folks with those resources, divert them from the criminal justice system, or give them alternatives on how to be engaged and get the help that they need. So the idea of zero intercept, for example, is before law enforcement is ever involved. I wanted to focus on intercept 0 and 1 because the rest of it is more specific to folks in criminal justice. And the reason that it's important to understand this is because sometimes we tend to think of, in a system development milieu like we are right now, tend to think of one resource as meeting all the needs. So for example, when a number of years ago we were talking about a mental health court, we thought that that would meet all of our mental health criminal justice needs. However, it does meet a need, and it's a very important need and a gap that we had, but it doesn't meet crisis response. Crisis response is the beginning of a process. It's not an end, it's a beginning into services. It's a beginning entry point. And so I think it's important to understand that not only because once we establish a crisis response system, we are finished, but because we have to then figure out where we go from there. What happens next? What are the warm handoffs? And so when we're looking at crisis now, it's a model of service that involves certain principles like trauma-informed care, harm reduction, engaging peers, warm handoffs to the next level of service, zero rejection rate. No one is rejected from engaging in those services. So when we are looking, let me start over a little bit and tell you what we have in place in our system and what some of our gaps are as we're looking at this system. I don't know if we can make it a little bigger, but perhaps you can refer your own material as well. Intercept 0 is the opportunity to engage folks before they have any contact with criminal justice. So 0 is where folks who are in crisis but not committing crime, or perhaps committing crime but are able to be engaged before law enforcement gets called. So somebody who is walking in the middle of the street, for example, instead or in lieu of involving criminal justice, we have a way of approaching it. And that is where crisis lines are involved, the mobile crisis teams that we are talking about, having a centralized call center where the community can call in, having the ability to respond to the community without necessarily involving law enforcement at all. If law enforcement is called, then we're moving into intercept 1. Intercept 1 is when the officer meets with someone on the street, realizes that there are some either mental health or substance abuse issues, behavioral health issues that then need to be addressed that take precedence over the criminal activity. Obviously, if the criminal activity is serious enough that charges need to be pressed, at that point the officer will proceed with that. But if a diversion opportunity is presenting itself because of the clinical needs of the person, at that point the collaboration between law enforcement and HHS behavioral health specialists becomes very important. When we developed the STEER program, we had initially conceptualized it to belong under Intercept 1. STEER is a team of peer specialists who have history in substance abuse. They were previously consumers themselves who have overcome, and they have become specialists in helping other people go through the recovery process. The idea was to have STEER be a deflection option for police officers. So if an officer met somebody with a serious substance abuse issue on the street, that they would call the peer specialist, and at that time, the person would engage with the peer specialist, engage in treatment, and charges would not be pressed. That would be a deflection. for various reasons, that program changed a little bit. It became more of an Intercept Zero program at this point. So we are engaging STEER at a very high rate of referrals. I think there were about 680 referrals last year of folks who were having serious substance abuse issues, but they were referred from the hospitals. They were referred by fire and rescue. The majority was fire and rescue referrals responding to overdoses. There was also a very high number, like I said earlier, from the emergency departments, calling the peer specialists, handing over those folks as they're getting ready to be discharged. But what is interesting is that it became an Intercept Zero and not so much used by the police as a deflection. What we do have as Intercept One at this point is our crisis intervention team. Our police officers are trained to have specialized skills in responding to behavioral health, but that does not replace the need for clinicians who can then come in and engage. It's, for example, what Oregon is using in addition to their CAHOOTS program. Their CAHOOTS program responds only to cases that do not require law enforcement to go with. If a case requires law enforcement to go with, then they have their own, the police department then has their own specialty unit that goes out and provides that service. In our system, we're trying to develop a system that takes responsibility for all of those cases and works in collaboration with our police department, if that makes sense. So instead of separating the two, we're trying to combine and serve both cases, those with law enforcement and without law enforcement. So that is the collaboration, and that is where a lot of what the Crisis Now grant would have helped us with, in strengthening those collaborations, in providing alternatives to the police officers with a place to deliver folks who needed crisis stabilization, and with peer specialists who would then be able to respond on the scene and engage, and with our mobile crisis team.
Thank you, Ms. Morrow.
Yes.
That is a really impressive model. A lot of positive implications in how we work with our homeless population. And his hand is up, and I suspect he's going to go there as our lead on homeless and vulnerable populations. Councilmember Glass.
Thank you very much, Mr. Chair, and your presumption is correct. So a lot to unpack here. You know, I've been following the conversation for the last hour, listening, because this is really important stuff, and you know, trying to move forward in a way that we hadn't expected with the loss of the grant opportunity. I think that you're putting forth a good faith effort to try and do what we can with what we have, at least at this point in time. And you know, the statistic that I state at every one of these conversations is that throughout my tours of our homeless shelters here in the county, the number is approximately 40% of those who are experiencing homelessness also have some form of mental illness, and that's from the providers sharing that data. And so the intersectionality of it all, we get that. With regard to this particular program and I guess public safety in general, you know, there's intersectionality there, and there's lots of national and local conversations about how we can do better in our public safety. And my question is, I think I saw it noted in the packet somewhere that regarding the protocol for 911, when people call 911, and the graphic that you just explained, I think is very helpful to visualize it with regard to the processes and how they're redirected. But is it always that simple? You know, sometimes there is a disconnect when people call in to 911, but can you share with us either, if not the training, but at least the background that those call takers have in determining what the next step should be, if it is a mental health, if it is a more immediate concern where a law enforcement officer needs to be called? Can you shed some light into the people behind these processes and how they make these steps?
Councilman, can I ask a question? I'm not sure whether or not that's a Dorney question or a Marcus Jones question around this, because
and I think that question is a good question. I don't know exactly who to direct it to, but clearly, again, the intersectionality of it. So if Dorney wants to start, and then Chief Jones, but yes, Dr. Crowell, you're exactly right.
Okay.
Sure, I can answer that. So the same therapists, clinicians at the crisis center answer the phones and do the screening. So their background is in mental health, behavioral health, substance abuse, domestic violence. We do trainings often, and we actually have been starting doing some training specific just for our staff. And we think that that works well, because that way they not only know the resources, but they know the process. They know the community. They can say, oh, yes, I know where that is, or, oh, this is what shelter. Okay. And we have a good relationship with our shelter partners. We meet often with services to end and prevent homelessness. We triage cases and work together. So for us, they are trained clinicians that answer the phone at the crisis center.
Thank you for that. And then Chief Jones, when the calls are transferred to you all, can you talk about kind of the personnel moments there?
Yeah, absolutely. So generally, the way this would work is that our call takers at our emergency communication center generally go through a line of questioning for whatever particular event is occurring. But that in all reality, they are going to dispatch to an officer to respond to that particular situation. Whether it's, it could be just, whether it's a disorderly conduct type of situation, maybe drinking in public, it would depend upon what the complaint might be. Or, if there's a stranger who may be calling to say that there's someone that's laying on a sidewalk that's not responding. Generally, again, they're just using those as some examples that, we are going to respond and allow the officer to make an assessment. And that's why we do some extensive baseline mental health training with our officers who are CIT trained at a level above our minimum, that gives them an ability to make some assessment when they get there, to make some determination whether there's some services that might be able to be provided, depending upon, again, what is the situation. If this is a dispute, are you just there as a peacemaker? And what is your role for that particular time frame? And can you make an assessment on the person particularly? Is this someone you come into contact often, or is this somebody brand new that we've never met before, that particular officer, given that situation? There's a lot of different dynamics. But generally, the call takers at our communication center will send that call over for dispatch. And only a police supervisor, which is sworn supervisor, if they deem that this is not something that the police should be responding to, they could override that decision to send an officer and maybe refer it to someone else. They're the only one who has that authority at that particular time, at that level, and monitoring the police radio dispatch to make some other decision, to make some changes at this time.
I appreciate that, and I know that this conversation is taking place in many other forums and venues here in Montgomery County, and so I'm not going to belabor it right now, because I know it will come back to us, and we will have a more full-throated conversation about the intersection here. But as it related to these points, I just wanted to raise it. And then the only other point question I have, here we do not decriminalize homelessness, and certainly do not criminalize mental health issues. But I know that it's challenging for residents and particularly business owners, as well as I think the chair alluded to. A number of us are working on issues in Silver Spring and in other parts of the county to make sure that everybody feels safe, from business owners and residents to those who need shelter. But when people are calling in, I'm curious about any public education or any types of communication that need to be shared with business owners and with residents who need some assistance in identifying where there are true public safety risks or individuals who need mental health support. Because again, you all are sifting through these phone calls and trying to figure out where they go, but people are still calling and they're contacting us as well. So I'm curious about a public education, not necessarily a public education campaign, but that's essentially what it would be, how we help people figure out the differences here.
So one of the things I would just point out is the fact that, in our district, in our different police districts, one of the things we try to just, particularly when we get calls from a particular business owner or a business community or a community member of a constant problem that we might be having, that there may be someone who has a mental health issue or an addiction issue that we're constantly dealing with. We have our community services officers working at those district stations who try to set up the liaison and a way of communicating with those community members to give them some options, and we'll share options. And in fact, we bring in sometimes our own CIT teams to try to help evaluate and assess the situations to try to resolve, the conflicts that might be occurring, whether it's businesses or residential owners or whoever in the community that don't feel safe, and try to give them some safety planning. And we do it more from, I would call it more of a micro sort of a angle, because the districts are more in line to know what is the problems going on in those particular communities. So I think for us, that's usually a winning combination, but it could be expanded even out further. I think if I'm following you, Councilmember Glass, so that there's a better sort of educational campaign in some of our communities, particularly the business community. But any community that, again, when you have these types of safety issues where people are concerned about, well, what do we do with an individual who's created these types of problems constantly, and how do we resolve this for us to feel safe, in the community overall?
Right. And recently they have been including myself and the mobile crisis team supervisors in the community meetings. The police have invited us, and we've also given some information and resources. Some of your council aides have been there with us, and we've been giving real-time action steps that they can do, things that they don't always know about. So that's another way we've been partnering to try and increase community awareness.
Great. I appreciate that. And as I said, we know we're going to have more conversations about this between public safety and mental health. And with that, I yield back to the chair. Thank you.
Councilmember Glass, before we move on, I just wanted a couple of things to add to that. One of them is that, of course, that as you well know, the Silver Spring area has been a place where there's been a lot of concern about this issue and a lot of discussion about it. And adding, I know through Seth and Amanda Harris, we've added part of our outreach community team and a liaison to the local community to try to address that. I kind of see that as part of a larger and continuous effort to educate the public about mental health, mental illness, rights, laws, and engage them in a conversation about what we might be able to do differently with folks that are on the streets. I do think that that this integration that we're talking about and this team that we're talking about becomes a part of that process. Embedding a crisis team in a local region gives them a chance to be more continuously engaged with folks over time. And I will stop by saying that my experience of this has been that no matter how much we talk about this issue of safety and mental illness and the risks and dangers of someone who is mentally ill, and talk about the statistics and the reality of that, when someone sees someone on the corner psychotic, responding to voices, obviously mentally ill. That kind of goes out the window and they get very concerned and anxious. So we have to continuously educate and respond.
You're right. Okay. Thank you, Mr. Chair.
Thank you. That was enlightening, very helpful. So another important component of the Crisis Now application was the development of the Community Crisis System Collaborative. And as Ms. Graham noted, there was a unbelievable collaboration of county organizations such as the MCPD, Montgomery County Fire and Rescue, the Department of Health and Human Services, MCPS was also involved. And then, of course, nonprofit organizations in addition to the hospitals, including Everymind. And it just, from all reports, it was a very formidable and powerful group. And so one of the components of the application was that group would continue and be the formal organizing body that would help to coordinate all of these efforts. And as Dr. Crowell noted in his introduction, there are a number of organizations doing phenomenal work from their respective positions. But collaboratively is when we really help break down walls and really create that system building we keep referring to. Are there plans to keep that collaborative together to be able to continue to do the work? And if so, what form might that take? And if not, what can we do to continue that effort and to continue that collaborative?
So, Councilman Rao will say what I said at the start of this is that I think that collaborative was an important element of creating this initial grant, this process, and it was a nice coming together of some of the folks that have always come together naturally around this, but also some new folks at the table to have some conversations. So I'm thinking that we will continue to make use of that. The constellation may change or may shift a little bit, but the important piece is that there's some core partners around this in our hospitals, our community providers, community stakeholders who have an interest in it, but also the core departments that we've talked about, and you've heard from them, they have to be at the table now to figure out how do we integrate some of those and build some of those pieces that we've discussed. And I think who's in may vary depending on the particular issue. We've got to come together now first and figure out exactly what our next steps are, both in terms of creating a more unified and coordinated response process, what that training needs to look like for all the staff that are actually on the streets and responding, what the call center process needs to look like and how we reform that. And then the longer term lift is what is the restoration? Well, let me back up. What are the alternatives for diversion when we encounter someone? And then the last piece is long-term. What is that restoration plan going to look like for us? So those are like the four major buckets of work that I see in front of us. And we'll bring general services to the table. The hospitals may have some thoughts about space and alternatives for how we might stand up a restoration center and staff it, of course. But that's the ongoing work. But those four major buckets, I think, are the pieces of the work that we have going forward.
I appreciate that, Dr. Crowell, and I know that this crosses over multiple divisions within DHHS. Do you have a lead that you've identified to help with the coordination of the group moving forward or being that representative, or is it going to be coming from PCCR, the Primary Care Coalition? Just how do we envision, who's the organizing body that will continue to do the administrative work that comes with coordinating schedules and bringing people together, following up on agendas, and so that it's not just another meeting, but that it's something that is actionable. Is that DHHS that we envision taking that role, or?
I'll take ownership for reaching out to Leslie and PCC and having a follow-up conversation with her about that piece of this work and how we move that forward. You're right. I think certainly HHS can figure out how to staff and move groups forward. We've been doing that for a long time, and we have to do some of that anyway to make this work. But I do think that there is a certain amount of labor associated with that, and a certain amount of infrastructure support that's needed around that. And you know where we are in terms of all the other things we have going on right now. So I want to have a conversation about how we structure that going forward, and I'll commit to doing that within the next 3 weeks or so with Leslie.
And I say unequivocally, obviously resources will be thin, to say the least, moving forward, but this remains a very high priority of this council, and I know of this executive branch. So as we look at potential third-party funding sources that are out there, hopefully another federal stimulus, I know we're committed to making this work. And so if there are resources needed, I know that we'll work hard on finding them. Ms. Graham, did you want to follow up on that?
Just to say that Dr. Crowell will get together. We do have a Nexus board meeting at the last Friday of this month. And on that board meeting is to talk about how to organize and prioritize the resources that are available. So I think if you and I can talk before that, that would be excellent.
Great.
Wonderful. One of the final items on the agenda, and Dr. Crowell, you alluded to this again, I appreciate it, is the 911 call taking protocols and the potential for changes to the system with the new call center. And now, unfortunately, that we're not getting the Crisis Now grant. I guess maybe Chief Goldstein, we can start with you on this. I know that obviously Fire and Rescue is a partner in the 911 call center along with MCPD and a number of other partners. But I know you in particular were excited about some of the efforts around the 911 call taking center. We've had other discussions around 911 in general. I didn't know if you had any comments or thoughts on this specific item, or if you want to defer to anyone from your team. Be happy to hear from them as well.
So good afternoon. This is Alan Bush. Chief Goldstein stepped away for a second, so I'm subbing in. I think our primary concern was, of course, the Restoration Center, and we share Chief Jones' dismay that we didn't receive the grant. We saw this as pretty fundamental to addressing some of the things that we're experiencing in terms of mental health and substance abuse patients that we're overloading our emergency rooms with. But that said, certainly looking at call center protocols, through our work with the ET3 model, which seeks to divert non-high acuity patients to other treatment pathways, we've looked at the emergency communications nurse specialist position, and there may be some overlap with what's being discussed with the mental health. But I think that this is all stuff that kind of needs to be explored in more depth and isn't going to be easy. So, Chief Goldstein, did you get back in and did you want to add anything?
Yeah, I heard that, and I'm good with what you got, Alan. Thank you.
Thank you, Chief Goldstein. And I made the mistake of skipping over Chairman Katz, who had his hand up earlier. So please, Chairman Katz.
Thank you very much. One of the good things about being skipped is that much of what you've had to say has already been said. So that's a good sign. But I did want to point out a couple little things. That first off, the obvious need, and Ms. Graham certainly pointed out this as well, and as to Dr. Crowell, but part of this whole thing has got to be the coordination of the various groups. And that in itself can be a tough thing, because as much as we want every group to be independent, we certainly want redundancy. We don't want only redundancy. We want additional help in every way we can possibly have it. So if that can be a possibility, we need to continue to work on that. And I we point out all the time, our resources are thin. Our resources are thin. There's certain resources that you cannot avoid. And these resources are the ones that we need to be doing. And as unhappy as all of us are that we didn't get that $17 million over a 5-year grant, the reality is that the $3.5 million per year, at some point we would have had to pay anyhow. The 5 years certainly would have been a help, and it certainly would have gotten us there faster, and we certainly wanted it, and we certainly hope we can get something else and go through that list. But grants run out, but problems don't in many cases, especially these types of concerns. And we were going to have to fund this these things anyway, this topic anyway. So I think we have to figure out a way to do it as quickly as we can. And to the point of how someone's going to reach us. You know, if you're in a crisis, and Dr. Crow touched on this before as well, but if you're in a crisis, that one of the things that you're not going to remember is, you know, an 800 number to figure out who you should be calling. I mean, unless it's on the side of every bus that happens to go by, you're not going to remember it. So that's why 911 is certainly something that everyone remembers. And we need to make certain that if people call 911, whether or not they should have called 911 or some other number, that if they call 911, 911 can figure out how to get them that help as quickly as they can and be trained to do that. And the last part I'm going to touch on is what Councilmember Glass touched on about the communication and the education side. I have lived through the business community being very upset over homelessness and all the problems that was associated with it in front of my store and other stores. And when after people said, you know, it's hurting business and, you know, this is all, you know, I've called the police 10 times and nothing was ever done, yada, yada, yada. But what we need to do, which is what we did many years ago, we looked at way beyond the person standing in front, but why was the person standing in front? And that's how we came up in Gaithersburg with the Wells Robinson program for people who were homeless and because of addictions, both alcohol and narcotic. But once we got past that, and once you got past the actual discussions of people not wanting them there, but once people realized that there's a way not to actually get a better life for everybody involved, you get a better life for the business community, you get a better life for the person who had the addiction problems, and we did it, and we've been able to do it. And people at the end, fairly quickly, I mean, the first couple of meetings weren't pleasant, but people fairly quickly, after you had those discussions, were extremely proud that we were able to help people get to a better life. And that's what we need to continue to do in this process as well. Thanks.
Thank you very much, Chairman Katz. I know that Amanda's on the line too. Ms. Harris, was there anything you wanted to add to this discussion specifically as it relates to homelessness?
Sure, I'm happy to speak. Thank you. So I think President Katz is correct that we do need to do more engagement with the business community, and we have been stepping up our efforts over the last, I'd say, 4 years. We have gone from a total of 4 outreach workers to now we have 13 outreach workers spread throughout the county. So we're definitely stepping up our efforts. It's still not quite enough, but it's a really critical component. But I think the important thing to remember is that we have housed more than 450 people over the last few years. We've done a tremendous amount of work, and most of the folks that are remaining on the streets are the ones that are incredibly difficult to engage. That we meet with them maybe not every day, but multiple times a week, and continue to do that work, and we're not giving up on them. But it does take a long time. There are some folks that it's going to take years before we get them to agree to come inside. So just having an understanding and a recognition of it's not that we have given up or that we're not aware, that we're not doing anything. We are deeply committed to doing this. It takes a long time. And we've gotten to the point now where it is very rare that we get a call from the community about someone who's sleeping outside or some concerned citizen that we don't actually know who that person is. We know them, we know their name, and we're working on getting them housed. So I think partnering more closely and better coordination with the crisis center will be really helpful. So our role is really to do that aftercare. We're not necessarily a crisis response, but we're the ones that can go in and continue to do that engagement. And the last thing I will say, because I would be remiss if I didn't say it, I think we also, as part of this, we need to look at the longer term mental health services. So the mobile crisis team can respond in a crisis, but there is definitely a need for more assertive community treatment teams that can do that long-term work, that have an integrated team that can do the street outreach, that can follow people once they get housed. That we have teams, and we have some strong teams here in the county, but we don't have enough. So I think that's something that we need to look at, and that's Medicaid reimbursable too. So there's not a cost associated with that.
Well, amen to that. You're absolutely right. That continuation of the system building is critically important, and I appreciate your responses. And having participated in the point in time count with my colleagues, Councilmember Rice and Councilmember Glass, I can speak in the first person about what you just described, Ms. Harris. Just the incredible dedication of the folks that are out in the community that do already have relationships with a lot of these individuals. But I think that this model really expands on the existing infrastructure that we have and will take it to the next level. And the crossover to law enforcement is very significant. So as we wrap up, I want to point out a couple things. I've received some interest from my colleagues. There's interest in getting a cost estimate for the peer recovery positions that would have been grant funded but were not grant funded. So if we could get those numbers as a follow-up, because there's interest in seeing what we can do about that. And then also, one last time, Dr. Crowell, any advocacy the council can do around Medicaid, engaging our federal delegation, is there anything that we can do to help around that area?
In relation to crisis, I think a lot of the work is initially at the state and getting the state to think about how it wants to fund crisis services and mobile crisis services, and then collectively going to the federal government if there are waivers that are needed for Medicaid to make this possible. The state has been working on crisis response pieces for a while. I don't think they've funded the peers. They have not funded peer recovery yet, and I don't know that federal Medicaid is actually thought of is at that level of thinking. So it may be that that's a driving. If we're going to drive one thing for me, it would be that we figure out how we fund that piece, that level of the service. The residential services, as Leslie mentioned earlier, I think are fundable largely under residential crisis as a model, but there may be some additional peer recovery support that might be built into that as well. So
I appreciate that.
That piece I think is most important.
Councilmember Hucker.
Can I just piggyback? That's helpful, Dr. Crowell. Thank you. Who in our state delegation, Senator House, have you been working with on that? Who would we follow up with?
I don't know in the moment around this. We have. I'd have to go back and look and see. That'd be a question for Melanie Winger to give us an answer on who's most interested in our delegation around this issue.
Thank you.
Okay, Ms. McMillan, we've, I think, gone through the packet. Was there anything that we missed that you would like for us to highlight? Or I think we've got the follow-up items, but was there anything else?
No, I think I have several follow-up items that I'll work with the department on to get back to you to keep these things moving forward. I did just want to say that I was happy to hear Mr. Katz bring up the mental health court right at the beginning, because as Mr. Katz and Mr. Rice will know, and this is why I asked on the sequential intercept to come back to this joint public safety and HHS committee. We're looking right now at the beginning of it. The council has always tried to look throughout the intercepts. We haven't had a chance for this joint committee to really do that, but mental health court was a big piece of that and became a priority. Restoration Center is in there. Issues around homeless dockets, some of the other issues that have come up are within those intercepts. And so I'm glad that the committee had a chance to get that broader picture today. And I will just work on following up with you on the issues around the mobile crisis response as soon as possible.
Thank you, Ms. McMillan. I'll note in the audience today was Dr. Rolando Santiago, who we will be voting on very soon to become our new division chief of behavioral health and will be an important part of this team moving forward. So we welcome you and thank you for participating or listening, Dr. Santiago. All right, that's it for today. Thank you all. That was a productive and helpful session. Appreciate everyone's hard work and look forward to convening again soon. Thanks a lot.
Thank you all.
Thank you.
Thank you. Have a good afternoon.
Traffic signal on Washingtonian Boulevard at Fields Road will be turned off for approximately 3 months.
information.